بدي اول نقطة بس انه اذا اللي بتقرأوا الشابتر هو شابتر E21 راح انزل لكم اياه ان شاء الله على الاي ليرنينج. هذا الشابتر PDF فايل، وبنزل السلايدات بعديها لما اجهز الامور كلها هاي ان شاء الله. بس في 2 توبكس تقريبا اختصرناهم. اذا تتذكروا احنا حكينا في البداية عن الكريتيكال كير، وحكينا عن neonatal cardiopulmonary resuscitation، حكينا على neonatal sepsis and meningitis. بيجي بعديها 2 topics ما راح يدخلوا بمادة الثيرابيوتكس 3، ف don't worry about them. وبنزل اعلان ان شاء الله على ايرنينج اللي هم الcongenital heart defects مش داخل، neonatal hypotension مش داخل، otherwise everything else داخل في هذا الامتحان او في هذا الكورس. فالتوبيك الأهم اللي راح نحكي عنه اليوم هو المانجمنت of pain and sedation in neonates. واضح يا جماعة؟ فأي سؤال بإمكاننا بعد المحاضرة إن شاء الله نعمل سكشن هيك أو 10 minutes 5 minutes للأسئلة. فهيستوريكلي طبعا البين والسيديشن it was believed that the neonates كانوا في السابق يعتقدوا إنهم ما بيشعروا بالألم. Especially those born prematurely were unable to perceive pain. Although it's now widely known that this belief was incorrect, the NICU patients, على سبيل المثال, they routinely undergo multiple painful procedures without analgesic therapy being provided, which is not a common practice or not a good thing. We have to provide them. They feel pain, they have perception against pain. فإذا كان في عندي failure to provide sufficient analgesia إلها يعني serious consequences. The various reasons ممكن يكون في عندهم inadequate pain assessment، يعني ما كان في عندهم مقدرة انهم، لانه ما بيحكوا هدول الاطفال neonates ما بيحكوا، فبالتالي بيكون في عندي inadequate pain assessment or fear of adverse effects. كانوا يعني يخافوا ما يعطوهم analgesia، يخافوا من الادفيرس افكتس، او الكلينيشنز ما بيعرفوا حجم البين او degree of pain او severity of pain. the consequences لو تركوهم untreated للpain, untreated pain can be significant, including serious consequences like exaggerated responses to painful and non-painful stimuli. You can imagine leaving somebody without a painkiller. Physiological instability. This will affect certain physiological parameters. Abnormal brain development. So you can imagine if you leave the subject or the patient, the neonate, untreated against pain, might affect their brain development. They might alter neurodevelopment in those children. So it's really important to treat pain in this patient population. In the NICU or the newborn intensive care unit, 2 types of pain typically are encountered. ايش هم هذول 2 types of pain? The first one is acute pain. Like in adults, they have acute and chronic. Acute pain normally associated with surgeries or procedures. So if they do any procedure, invasive procedure, they would feel pain, like a heel stick to take a blood sample for blood work. بالعاده بياخذوا منهم البلد سامبل من الكعب الرجل للاطفال النيو بورز او نيونيتس، او اذا مثلا بيعمل other procedure او invasive procedure like endotracheal intubation, sticking a tube into the trachea. So that's an invasive, causing them pain. They will start crying, and that's physical instability. The other type of pain in the NICU is a prolonged pain. That prolonged pain caused by diseases. Example, the NEC or some interventions. Some interventions, they might also cause that type of pain. Mechanical, for example, ventilation, chest tubes. So these kind of, on the long run, they cause them a prolonged pain. Sometimes environmental factors also may contribute to discomfort. What is around the baby? What's around the baby is the temperature of the room. It's too cold, too hot, might cause them some pain. Soiled diaper, they don't change diapers frequently, they might also cause them some pain. positioning, the way their body is. If you squeeze the body between two things, for example, you cause them pain. So these should be addressed, and noxious stimuli, the source of that pain, should be removed before a pharmacological intervention is employed. So you ask yourself the question, what is the underlying reason for this pain? Can I treat it before I try any pharmacologic option or modality, right? So that's something you can do, also trying to avoid or remove the noxious stimuli. Self-reporting of pain. Normally, if I ask anybody of you, you have a headache or you have a tooth pain, you describe that pain. You could talk about it for maybe half an hour or in a couple of words or one word even. But those children, don't forget, the neonates, they are pre-verbal. They can't speak at this time. So there are other parameters to evaluate the degree of pain in this patient populations and sedation in neonates. The first one is physiological. So you rely on other parameters, other signs and symptoms to see how much pain do they have. For example, heart rate change. When you do a procedure to them, let's say you inserted a tracheal tube, then you feel the heart rate starting to pumping the heart very quickly. You feel that they are in pain. Behavioral, what behavior or reactions do they express? Facial grimace, crying, other movements of their body because they are taking some pain and their body is fighting against by making some behavioral actions. So these objections or observations, they can be subjective and biased. So it depends on the clinician who is treating the child. How do you know if this is severe, mild, or moderate? We don't know. So the presence of pain response and its magnitude in those children might be affected by gestational age, or GA we call it, the postnatal age. The age of the neonate is really important. We'll give you about the presence of the pain response and the magnitude of that pain, in addition to the illness severity. How severe is that illness under study? Neurological impairments, which further complicates assessment. Do they have neurologic factor or impairment in those patients? So how do we assess pain and agitation in children? So the assessment or the use of pain assessment scale is recommended to better standardize this practice. So always it's better to standardize things, to start to compare the severity or a scale. But many tools have been developed in an attempt to better, of course, assess this pain in neonates. But however, most have not been validated using psychometric testing. So there are certain methods, but they are not validated. Again, the reason for that, because these are pre-verbal patients. Most of these tools have only been validated for a procedural. Example, acute pain, not a prolonged pain. So if they have a pain for a certain invasive procedure on the short run, they are validated for that, but not on the prolonged pain. So some tools also utilize both physiological and behavioral parameters. We mentioned about the behavior, how the child would behave in response to pain, or the physiological changes like heart rate, as we mentioned, while others only consider behavioral variables. So the tools have also been validated in varying gestational and postnatal age range. So different ages, they have been validated. No one pain assessment tool will be appropriate for use in all NECIO patients. Regardless of the tool used, assessment should be done after each intervention to determine its effectiveness in relieving pain. So this table contains the most commonly used neonatal pain assessment tools. So the first one is, I'm not going to go through everything, but the premature infant pain profile, PIPP, the type of pain assessed. Mostly you will see in acute, some of them are prolonged, and the NPAS score, the neonatal pain, agitation, and sedation scale. In addition to pain, it's also used to assess level of sedation. Therefore, I highlighted that because it's also applies to assessment of sedation, not only pain. So sometimes we're interested, if we give them a sedative, we need to get them sedated. We need to know about the degree of sedation. How can we measure sedation in those? So again, this is the population, what age is appropriate for each method, and the parameters included. Behavioral states, heart rate, oxygenation or saturation, the brow bulge, the eye squeeze, nasolabial furrow, facial expression, crying. So several parameters are included in this evaluation or in this scale. So the assessment of non-pain related distress can be even more difficult in neonates. Many of the physiological and behavioral findings, they overlap with those observed in neonates suffering from pain, drug withdrawal or delirium, and agitation or under sedation, because they did not receive enough dose of that sedative, may contribute to accidentally displace entero or endotracheal tube and IV catheters. These are invasive procedures, as well anxiety and fear in neonates. They are developmentally unable to understand and cope with the stressful conditions yet. So conversely, oversedation, if you give them an overdose of a sedative, can result in a prolonged need for mechanical ventilation, longer duration of hospitalization, increased healthcare costs. So again, you don't want to go underdose or overdose in those patient populations. So what are the non-pharmacologic approaches or options to manage pain and sedation in children? So number one, there are quite a few procedures or measures you could follow. Reduce the number of painful interventions. So whatever that intervention is, for example, reduce or limit the number of blood sampling, how many times you would draw blood from those infants. Instead of having 5 times a day, can you limit them to 3 or 2 or 1 maybe? So think about that. Coordinate or bundle the bedside care. Example, if you are doing a lot of things, so do them at once instead of every time you bother the child and do, for example, diaper change, physical examination, endotracheal tube suctioning to allow the neonate longer period of restfulness. So this way we'll give them more time to get rest instead of every hour you, for example, go and change the diaper, then another hour or two do physical. So bundle them, do them all at the same time. So this way you just disturb the child only once if possible. So when painful procedures are necessary, non-pharmacologic modalities should be the first tier of interventions used. So we're trying to run away from medications if possible. So therefore, you first follow the non-pharmacologic modalities. Swaddling, as you see in the picture, this is a swaddling, kind of you tight the body of the child. Non-nutritive suckling, let them suckle on something like a pacifier or something. Some people, they might do skin-to-skin care. Keep them close to your skin, commonly called kangaroo care. Massage, breast or bottle feeding, If they are crying, if their mother, they kind of breastfeed them, they would calm down or give them a bottle. Most effective when used in combination also with each other or as adjuvant to pharmacologic therapy. So if you add two of these or more than one of these measures, it's synergistic or combination have a higher benefit. Or if you sometimes combine them with the pharmacologic agents that we're going to talk about them shortly. So let's start with the pharmacologic treatment options. And the selection of the drug or the medication, it depends on the indication, which in turn depends on the type and severity of pain and the need for sedation, for example, and the side effect profile. So two things is the indication for that medication, what indication we are thinking of, and the side effect or the safety profile of that drug. So suggested neonatal dosing is unfortunately not supported by well-designed pharmacokinetic and outcome studies, because most of the studies on medications normally they are done on adults, but not or never on neonates of various gestational and postnatal age. This table gives you some of the medications that normally use to fight against pain and to induce sedation. The first one you might have heard or you might not have heard of sucrose. Sucrose 24% solution used as analgesia for mild procedural pain. So the dose or the dosage regimen for everyone depends on the age or the body weight. So we'll take body weight now as a guide for the right dosing. So if the baby is less than 1 kilogram, then you give 0.1 milliliter per dose. You stick it in the mouth of the baby. So administer it 1 to 2 minutes prior to procedure. Give them a solution of 24% sucrose solution. Maybe apply to a pacifier or directly into the tongue of the baby, but don't exceed 3 doses per procedure. So that's before you do the invasive procedure, you give them that sucrose solution. The other thing you can give medications, very common, and you know it, is paracetamol or acetaminophen for analgesia in mild to moderate pain, post-operative or prolonged pain, also as analgesic for moderate to severe post-operative pain, but in combination with an opioid. Sometimes you give it as a monotherapy, but in cases of moderate to severe, you have to combine it with an opioid. And the middle row is, or column is the dosing regimen. It could be given as oral or intravenous. So it's not effective for acute procedural pain. So if you give some procedural pain, it's not effective to give acetaminophen because the pain is acute. The third option you have, or the third drug, is morphine. Morphine as analgesic. It's reserved for moderate to severe pain. For prolonged or post-operative pain, it could be given as intermittent intravenous or as continuous infusion. And again, there are certain precautions also with the use of morphine. Fentanyl also is used as analgesia. It's an opioid analgesic used in in moderate to severe pain, acute procedural pain, prolonged or post-operative pain. So there is an advantage over morphine. It's used in acute procedural pain. Again, it could be given as intermittent intravenous or continuous IV infusion. Midazolam is also one of the benzodiazepines. It's a sedative. They give it in procedural or prolonged as intermittent intravenous or continuous intravenous infusion. The other drug is dexmedetomidine. It's kind of a sedative analgesic for prolonged cases. It's given also as continuous intravenous infusion, but unfortunately we have limited data in neonates. So let's start with the first agent we mentioned is the sucrose, or 24% sucrose solution. It's an oral sucrose administered 2 minutes before mild to moderate painful procedures. Has been shown to reduce the PIPP score. We talked about it in the table. The exact mechanism of action, how sucrose works, is unknown, in fact, but sucrose may stimulate endogenous opiate and endorphin pathways. So this is the believed mechanism of action to mediate pain response. And the optimal dose, by the way, is not known, but typically they give 0.1 to 1 milliliter of 24% sucrose solution administered on the tongue of the baby or buccal surface. So effects are potentiated. We give it with a non-nutritive suckling like a pacifier and or swaddling. So kind of two measures at the same time. And the duration of effect is really short. It's about 4 minutes. So doses may need to be repeated during longer procedures. So sometimes the procedure really quick, within a few minutes you'll be done. So that's ideal. But there is a risk of hyperglycemia if you keep repeating this sucrose administration. So there is a repeated dose may cause hyperglycememia, NEC, and worse neurodevelopment. So might also lead to neurodevelopmental problems. Most commonly used drug is acetaminophen. And acetaminophen, it's used in mild to moderate pain in NICU, slow onset of effect compared to other options. Not ideal agent for preventing any treatment of acute procedural pain like heel stick or venipuncture. Incubation, it's not an ideal solution for that. The advantages reduces the opioid requirements by more than 50% in moderate to severe pain. So again, we mentioned in moderate to severe pain, we can give acetaminophen, but it's in combination with an opioid. This way you can reduce the dose of opioid. You know, metabolism of acetaminophen get metabolized in liver, and the glucuronidation, but in those neonates, it's kind of a little bit of different pathway. Instead of having the usual glucuronidation, here the main pathway for metabolism in neonates is sulfation, and the sulfation is an advantage, or it has a protective effect to the neonates against acetaminophen-induced acute liver injury. There is a metabolite, it's called N-acetyl parabenzoquinone amine, or NAPQI. This is a toxic metabolite, is normally formed by oxidation. So children or neonates are protected against the formation of this toxic metabolite. So this NAPQI is detoxified by glutathione, the synthesis of which is increased in neonates. In older children and adults, sometimes if we exceed acetaminophen dose, then if they have a shortage in glutathione, then they will have toxic effects of acetaminophen in liver, and that's why we say it's hepatotoxic. Don't exceed the 3,500 milligram per 24 hours in adults. Children, we have to also go below that. So there is association between prenatal and early postnatal exposure to acetaminophen and development of atopy, autism spectrum disorder, and attention deficit hyperactivity disorder. So we need to also think about these things. While causation and the pathologic mechanism is not proven yet, but there is kind of an association between acetaminophen. Therefore, we need to limit the use of acetaminophen if there is no real indication for that. The other drug we could use also the COX-1, cyclooxygenase 1 inhibitor. This is the most common agent in this group is ibuprofen. May not be as effective in premature neonates because of decreased receptor expression in the spinal cord. So its use then it's limited مقارنة بالacetaminophen. And this finding, along with the associated adverse effects also like nephrotoxicity, platelet dysfunction, gastrointestinal bleeding, making the COX-1 inhibitors non-ideal choice for analgesia in neonates. Maybe children, older children, yes, but in neonates, it's not an ideal choice, of course. The third category is the opioids. They are reserved for moderate to severe painful procedures in the NICU. Morphine and fentanyl are the most commonly used opioids, although the American Academy of Pediatrics recommended, but safety and efficacy of scheduled continuous analgesia during prolonged painful events remains in question. So certain procedures, you have to question their use, like circumcision, طهور الأطفال للذكور, chest tube replacement or replacement, and endotracheal intubation. So it's questionable. And opioids are often administered to mechanically ventilated neonates to prevent pain and provide sedation in this age group. Morphine, when it gets introduced into the body and distributed, then it will undergo metabolism, will have glucuronidation to two active metabolites. So it's the parent is active and two active metabolites. In neonates who are less than 10 days old, they have about half the glucuronidation activity. So this way, they will have a higher dose of morphine in their body. Therefore, we have to lower dose of morphine in this case. Fentanyl clearance is correlated with gestational age. So as they grow younger, then clearance will be different. So neonates with younger GA have a slower fentanyl clearance, then the dose should be lower because their clearance is slower. Increase in clearance occurred after around 2 weeks postnatal age. So the first 2 weeks, they are critical. We have to lower the dose of fentanyl as compared with the neonates after 2 weeks of age. I'm going to talk about some of the most common adverse effects of opioids. As you know, they might cause hypotension, and it's more with morphine as compared to fentanyl due to histamine release. They might cause impaired GI motility, and you know that would cause constipation. It's also more with morphine as compared to fentanyl. They cause respiratory depression, both agents, and they need mechanical or prolonged mechanical ventilation if they cause that respiratory depression. Chest wall rigidity, rapid administration of fentanyl, if the dose gets infused over very short period of time, like within 3 to 5 minutes or shorter, they might develop chest wall rigidity. In these cases, then naloxone or a neuromuscular blocking agent should be used to relax the respiratory muscles and facilitate ventilation. Tachyphylaxis, both agents, fentanyl and morphine, but occurs more rapidly in fentanyl as compared to morphine. Physiological dependence, and this also predisposes a neonate to withdrawal symptoms if these agents are abruptly discontinued or too rapidly tapered off. If you suddenly quit or discontinue that medication, the opioids, or taper them very quickly, reduce the dose very quickly, then they might suffer from withdrawal symptoms. Neurological outcomes also for opioid analgesics, they get conflicting results. Some of them they said yes, some of them they said no. So the opioid exposure during early brain development, it might have some problem. It might result in a neural cell apoptosis and reduced neuronal concentration, manifesting as reduced brain growth, impaired motor movement, and it might also lead to learning disability. So it's really important to know if this is really important to give this medication or not because of these neurological outcomes. So preterm neonates who receive continuous infusion morphine or midazolam while mechanically ventilated may have higher incidence of intraventricular hemorrhage in the ventricles of the brain, or PVL, periventricular leukomalacia, or death. So you will see the complications of preterm neonates if they are receiving these opioids compared to neonates who are receiving fentanyl or no sedative or analgesic at all. Therefore, morphine, midazolam, while they are on a ventilator, they should not be receiving these. The alternative is giving fentanyl analgesic. Long-term complications with morphine, also in some preterm neonates, would include impaired motor development, lowered intelligence quotient, and altered short-term memory. Therefore, fentanyl is preferred over morphine. The next group for sedation is benzodiazepines, and you all know benzodiazepines. They are commonly used for sedation in the NICU. Unlike the opioids, they don't provide a beneficial analgesic effect. They are just sedatives to reduce stress, anxiety, and maybe also used to induce sedation in those children. Midazolam is the most commonly used benzodiazepine in neonates. The advantages, or why do we use it the most? Because the short time for elimination compared to other lorazepam or diazepam has a longer action or duration of action. Midazolam is also available in a preservative-free formulation. But on the other hand, it lacks well-designed clinical trials to evaluate the efficacy and dosing of midazolam, makes it difficult to provide an evidence-based recommendation. There is no definite dose regimen for children. It needs to rely on experience. So there is no evidence-based recommendation for midazolam. What are the side effects or adverse effects of benzodiazepines? Mostly respiratory depression, and hypotension might also happen, similar to what we have in the opioid use. They may exhibit myoclonic jerks, especially maybe misconstrued with seizures or get confused with seizures. This is a side effect of the drug, not due to, for example, an epilepsy. Midazolam for sedation during mechanical ventilation may have longer lengths of hospital stay. So it increases hospitalization than those who do not receive midazolam. So early benzodiazepine exposure may result in reduced formation and increased apoptosis of a neural cell. Again, they will also affect the neurodevelopment. So they might result in poor long-term neurodevelopment with early benzodiazepine use or exposure in those children. The other drug, dexmedetomidine, It's an alpha-2 adrenergic receptor agonist. Effective, they found it as effective a drug and as a sedative and analgesic agent for adult patients. Therefore, they tried to use it also in neonates, but a few small clinical reports have demonstrated its effect in the NICU. The optimal dose has not been decided or delineated yet, but pharmacokinetic studies indicate younger neonates require lower weight-based doses. So if you adjust for body weight, they need a lower dose as compared to adults. The advantage of not affecting respiratory drive, therefore the duration on mechanical ventilation would be shorter for those on dexmedetomidine as compared to morphine or benzodiazepine. So gastric motility is minimally altered with this drug, and neonates tolerate enteral feeding sooner than when treated with opioids. But the animal models have shown a neuroprotective also effect in subjects using the drug, especially in subjects exposed to hypoxic ischemic insult. And neonatal reports have also demonstrated similar rates of intraventricular hemorrhage or periventricular as in a neonate treated with fentanyl. So if you compare it with fentanyl. So this potential neuroprotective effect is kind of adds to the interest in using this agent for sedation. So it's kind of a preferred to be used for sedation and analgesia in the NICU, but there are certain disadvantages or drawbacks because the potential to cause hypotension is a concern for its use in neonates. The other thing is, like other opioid and benzodiazepine use, we have withdrawal symptoms. They have been reported upon weaning and discontinuation of dexmedetomidine. So that's the last thing I wanted to present today. And with this, we are done with the course, the last part of this course. فكل عام وأنتم بخير.